en réanimation avec 3 orateurs experts dans le domaine. Et j'ai l'honneur donc d'accueillir le professeur Claudia SPIES de Berlin qui fera sa présentation en anglais. Je demanderai d'ores et déjà aux personnes qui souhaitent poser des questions de bien venir au micro pour que les traducteurs qui travaillent au fond de la salle puissent assurer la traduction simultanée.
Okay. So thank you very much for your introduction. Bonjour, mesdames et messieurs. My French is not good enough, so I think I prefer to talk in English if that's okay for you. So, delirium and outcome. We have a high hazard odds ratio for patients who have delirium, so they die more often. They have more dependency of care after their discharge from the ICU, and people in the ICU being discharged from the ICU having delirium have a higher dementia rate. So the cognitive risk is increased, the mechanical ventilation is increased, ICU and hospital stay is increased, and also costs are increased. So we only see this short period, and afterwards I think it's very important that delirium as an organ dysfunction being very relevant afterwards for the patient's quality of life. There are new criteria on delirium, and this is the DSM-5 criteria, and all of them have to be fulfilled. So you have the disturbance in attention and awareness. You have this fluctuating course, and it develops over a short period of time. You have this disturbance in cognition. It's not explained by another pre-existing neurocognitive disorder. And I think this is very important, and this is new in the DSM-5. Does not occur in the context of a severely reduced level of arousal, such as coma. I think this is important because this will change the frequency measured in the ICU very much. Disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal, or exposure to a toxin, or due to multiple etiologies. I think this is important because this changes the validated scores as well. So looking on this, you can see that the majority of patients do not have a hyperactive stage. This is usually very well taken by the nurses because they don't let you have the state in the patient. The hyperactive is quite comfortable. The patient is lying in the bed, is very often smiling, is disoriented, cannot really concentrate, and you can measure that delirium. And you see here that they do not really concentrate on this discussion, and also very often very disoriented. And you had a very good score. I think this is a French score, and we translated it and we use it, the score, in our recovery rooms, in the peripheral wards. And if you don't have trained staff in your ICU, we use that score also for untrained staff in the ICU and for the relatives to judge that. And this is on disorientation, appropriateness, communication skills, hallucination, and psychomotor retardation. And if there's any change to the previous state, it's mild or severe, it gives you a point or 2 points if it's severe. And in total, if it's 2 or more, it's very suggestive of delirium. And I think because you can do it all over your hospital, it's easier maybe to implement it than to train different staff in different wards with different scores, sometimes difficult. Doesn't need any training. This is different. This needs training. If that's not done with training, it's not possible to use it. And I think the interesting thing is that you also have a fluctuating course, And you can check for inattention, and you can use abracadabra. I think this is very easy to notice. And you go to the patient, you spell that word, and you ask the patient to either raise the hand or press the hand. Each time the patient hears an A. So if you say abracadabra, you say A, then the patient has to press. If you say B, then the patient is not allowed to press. And you spell that word, and each mistake is summarized, and if you have less than 2 or less mistakes, it's not it's not a delirium. If it's more, you have to check for the level of consciousness. And they take the RAS here, and they say, and this is why it's different to that it's previously taken, because they say RAS, all RAS scores except 0. And this is wrong now with the new definition, because if it's less than -2, for example, then it's not delirium anymore. That's difficult, because we have different frequencies in the ICU, and they range between 30 and 70% usually, and it's probably in the middle somewhere now. 30 to 50%, I guess. It's not that high range, because the high range is was usually due to oversedation. So, and if you have all these, if it's also fulfilled, the RAS is 0, then you check for cognitive thinking disorders. And also you ask some questions. So is stone floating on the water or something like that? And you check also 2 and more errors gives you confusions, less than 2 errors, no confusion. If you take that all together, yeah, that CAM-IC usually can stop here, because the patient cannot really have that attention, and then it's finished, it's delirium. So we also have that algorithm, and we put that in an algorithm to evaluate, to avoid oversedation, to avoid inadequate analgesia, and to adapt that to the needs of the patient. And if you have a RAS score of 0 or -2, that means the patient is able to fix your eyes for 10 seconds. Then you check for this delirium score. If that's positive, also check with the other things, but then you are sure that the patient is not oversedated. And if the delirium score is positive, you immediately treat the patient. Symptom-orientated, plus you check for the causative agent. So, for example, say again, if it's sepsis, you have the infection as focus. So you check for the focus of delirium. And in addition, you treat the organ. So that means if you have hypotension, you treat with norepinephrine and volume. And here you treat with the different drugs you have available, and also with the non-pharmacological methods. So I think besides the symptom-oriented therapy, it's important to find the cause, and I think this is a good memo. I think I watch death, and the most often infection is a predictor of sepsis. But also we have other things: withdrawal, acute metabolic, glucose oscillations, often given you delirium, etc., etc. Hypoxia, anemia. So you can see a lot of causes you can check for, and if the causes are relevant, you need to treat them as well. There are also different risk factors. So one point is that you have a predisposition, that means age or cognitive state before, or use of psychotropes, and you have precipitating factors like surgery or admitted to the ICU, or concomitant diseases, or pain, or sleep disorders, or physical restraints, or urinary bladder catheters. The pathways are not so easily understood. There are many pathways. I want to focus a little bit on the initial one, because the initial one is very important, looking on this microglial activity, cholinergic pathways, and the inflammation. There's a lot of data available right now. it's very often the inflammation that's triggering this organ dysfunction. So you see that before you have sepsis. And there are several studies that are published on this issue. And sepsis was predicted by delirium has a worse outcome. Looking on the interaction of the immune system, you can see that usually you have exogenous ligands and endogenous ligands triggering your system, your immune system, and via IF-kappa B, or NF-kappa B, that's you get TNF-alpha response, for example. And this is important because this is shown previously by Mervyn May's group that this is a trigger for delirium. In addition, this cholinergic pathway works. So, for example, if you have inflammation, you have this crosstalk between the brain and the periphery, and that goes in the efferent arch, and then you can see that on the macrophages, you have acetylcholine receptors that are decreasing the immune response, and then you have less inflammation. This is shown by several colleagues now from an experimental state of view. Looking on the systemic infection, usually have TNF-alpha, you have that on resting microglia. Usually this is, if you have that, you have a cholinergic inhibition of that, then you have activated microglia, and then you have this delirium. If you have an elderly patient or a neurodegenerative disease or an anticholinergic agent, you have a primed microglia. And then you have a reduced cholinergic inhibition of that microglia, have overactivated microglia, neurodegeneration, and severe prolonged delirium. And it's a continuum to dementia. And these factors leading to priming are old age, neurodegenerative disease, drug treatment, and previous delirium. So on the microglia, the systemic cytokines, a local immune response, migration of macrophages, and you have this loss of inhibitory effects with cholinergic inhibition and an altered neural activity. That gives you local inflammation and the neurotoxic response. We checked for that as well. It's a study that we did with the LPS stimulus in the abdomen. It was a low dose, no animal died from that, and we looked on the hippocampus and some other slides of the brain. And as you can see here, 24 hours later, you have an increase in the hippocampal area of IL-1 beta, and this can be reduced by cholinergic agents. That means physostigmine and neostigmine. Neostigmine usually doesn't go through the blood-brain barrier, and we thought it's different, but it was not. So it seems to be a breakdown of the blood-brain barrier that happens quite early. And cholinergic agents seem to reduce that neurotoxic effect. We also found that if you look on the neurodegeneration of the positive neurons, you see that OPS and LPS are green spots here. You see that with LPS stimulus and without cholinergic agents, you have a decreased neurodegeneration, and using physostigmine and neostigmine, that was not, it was very much decreased. In addition, cholinesterase activity was reduced. I think this is a very good study from Taranto on the activation of the alpha-7 subtype of nicotine acetylcholine receptors that prevent TNF-induced NF-kappa activation. As you can see here, this is surgery. And usually if you have surgery, you have a breakdown of the blood-brain barrier, and you can see here the fibrinogen deposits on this area, on the hippocampus area. And if you look at that, you see that it's EF-kappa B related. And if you take EF-kappa B depletant alleles, you can see that the neurotoxicity is decreased, and In addition, the surgical responses doesn't show you also this effect. So you have a decreased neurotoxicity due to this IF-kappa-B reduction, and this prevents this TNF-induced neurotoxicity. In addition, if you use PHA, that is a cholinergic agent, you see the same thing. You have the same situation. That means cholinergic agents also reduce your neurodegeneration in the initial phase. I think this is important to know that there's on one hand a crosstalk, on the other hand the cytokines are still relevant. And if you look at this here, and these red spots show you the neurotoxicity, and here is the area where the macrophage migration is prevented if you use it's a acetylcholine agonist or if you use anti-TNF-alpha. That means this is shown several times now that blocking the TNF response, for example, and stimulating the cholinergic, nicotinic response decreases the neurotoxicity. What about our patients? And I think this is relevant. And in particular in elderly patients, you have a high load of cholinergic agents. That means, and this is a study published some years ago, you see that mild cognitive impairment is seen with anticholinergic agents. If 80% of the users had that with multi-drug use, and I think it's very important that this predicts mild cognitive impairment in these patients. And you can measure this SAA load if you look on the different drugs you are giving, like antipsychotics, antidepressants, antihistaminics, muscle relaxants. There's a lot of cardiovascular things like diuretics or antihypertensives, antibiotics, drugs for anti-anxiety. There's a lot of things that's giving you anticholinergic risk. And if you add this risk, you can see that your patient has a higher risk for cognitive disturbances. In addition, not from the initial phase, when the blood-brain barrier breaks down, when you have severe infection or you have a trauma or whatever, you can see that in patients with progressing dementia, and this was done by our neurologists, and as you can see here is that they had 24 patients with a progressive dementia situation in the ICU, and they took the liquor and they put it on the hippocampal slices of, and they found in an animal model, and they found that it's IgA-mediated autoimmune response. And as you can see here, the NMDA receptors are downregulated in the patient's serum and in the liquor. And what you can see here, 7 days later, when you rescue that by removal of this NMDA receptors, you find an increase of the NMDA receptors, and also the currents due to the NMDA currents is reduced if you have less NMDA receptors, and if you remove that, the current is restored again. So I think this is important to know that this is also an option that might work. And in our situations, for example, there's only small studies on that, but in intracranial pressure, they are from our neurosurgeons. There's a lot of data that ketamine seems to be neuroprotective. In addition, if you have a severe trauma like cardiac surgery with extracorporeal devices, there seems to be also a prevention of ketamine. And if you use 0.5 milligrams per kilogram, that reduces the delirium rate. So maybe this is in a later state, or in the initial state when you have severe inflammation, maybe this is also an option. It might not work in all patients, but at least in those being endangered to have this autoimmunity. There are also factors of the environment, I think, and I think this is important, that sleep deprivation is a major issue besides this ischemia, hypoxia, inflammation that giving you delirium and neurotransmitter imbalance. And I think this is important because sleep deprivation in the ICU is often due to noise. And if you look at this here, the ventilator alarms are 70, 80 decibel. That means it's a lot above the WHO recommendation of 40 decibel. And I think it's important that we try to reduce that noise level. There was a good study published, I think, with these earplugs. Maybe it's not perfect, but it's a good idea, I think, and to find out what the relevance of earplugs is to reduce noise level. And you can see for delirium it's probably not enough, but for mild confusion, cognitive impairment, it might work. In an initial phase, better than in a later phase, because maybe people felt isolated. I don't know. Maybe this is also an option to better investigate to reduce the noise levels. In addition, light. There's not enough light in the ICUs, also not in the rooms. If in cloudy days, even less than in sunny days. And the average in the bed is less than at the window. And outdoors, the light intensity is much more increased. And there's adjusted cumulative ICU insulation, as you can see in spring. It's much better than it is in fall and winter. I think it's important that we consider that, looking at our patients, to find ways that the light intensity should be increased. And if you look at that, we have a new setting, and also these colleagues from Utrecht had a very good idea to increase the light setting. As you can see, even with light in a new setting at a window gives you a better light value for your patients. And it's not much difference, but it's difference in days of delirium. Also, the circadian rhythm is decreased if you have no normal light in your ICU. So light is suppressing your melatonin response, and if you don't have enough light, you have not an adequate melatonin response during the daytime. It's usually going up at night, going down day over, going up at night. This is a normal rhythm, and you have a totally different picture in ICU patients. And there's some idea to give melatonin. I'm not so sure, it's a small study, but still the delirium incidence is reduced in elderly patients if you give melatonin for the night. And it's better than probably giving propofol or something like that, because propofol is, as you can see here, without propofol and with propofol, and we often do nocturnal situation. We did that the previous days, and as you can see here, you only have to look on the green and the red spots, and without propofol you have more REM sleep and more slow wave sleep. That means if you have this forms of sleep, you have a better sleep. This is the only sleep that has a high quality. If you have this light sleep, you usually don't sleep, and with propofol you don't sleep. And so the nocturnal sedation is probably not the way to do it. Except for melatonin, this seems to work. Non-pharmacological methods is to reorient the patient, stimulate cognitively, use classes and hearing aids, perform a better quality of sleep and a circadian rhythm, decrease the noise and adapt the light, and mobilize the patient as often as you can, and avoid any noise and any procedures at night. And we didn't find a good solution for our patients, to be honest, and we still had 100 decibel levels and had a lot of discussion. And then I tried to find an architect, and my business colleague helped me to find it. They had a business meeting. I was an architect, having built the house of Brad Pitt and some dentistry things to reduce the pain level. And then we discussed it with him and looked at the literature and found out that we can use some evidence-based information from the literature. There's one study that was done, Science, in 1984. It's an old study. And what they did, they had a group of patients, and one patient group looked at a wall and the other looked on the trees. And as you can see here, that these patients looking on the wall needed higher analgesic dosages and were longer in the hospital. So probably surrounding helps to stimulate our self-healing competences. So this is often overseen in our ICUs. And we had after that, we had a discussion with the architects, with the media design things, and I think this is the first time that this is really done internationally. And I think we are happy that we found these colleagues because we couldn't do it. And as you can see, you have a totally different architecture and you have a media design. And we do some cognitive stimulation by the system, by the LED system. We have 6 layers. And I will show you how it works. And this is our media design.
Berlin Charité Hospital is carrying out research on the positive effect light has on people. A small intensive care unit has received new lighting. 2 4-bed rooms have been redesigned to offer patients more privacy and comfort. Illuminated ceilings are supposed to promote healing.
Sunrise and sundown gives us a day-night rhythm that makes us sleep better at night. There are green elements in the room. You can see them up here. That shade is conducive to feeling protected. The space has been designed architecturally to make it seem like a living room rather than that storage area feeling you get in other IC units.
Well, it stops here to some reason, I'm not sure. And this gives you the cognitive elements you can use in the LED layer. I'm not sure if that's working right now. So the patient can do it by themselves, and they have interaction by the screen, by the nurses. So you put in the pain level, the sedation level, and the delirium level, and then the screen adjusts to that level. So for hallucinations, you have no movement of the screen, and if the patient has no fear, there's more sun and less screen and all that thing. So it's interactive. And in addition, you have cognitive elements to stimulate the patient.
Mainly it is that there's light above and it's not so loud. I think patients enjoy it.
So the cognitive things, I'm sorry, it's not working fully, but I think the fireflies give you a cognitive stimulation, so the patient can follow on the iPad to get cognitive stimulated. And I hope at the end that we have pharmacological and non-pharmacological methods. And I think this might help to get the self-healing of the patient in a better way. Thank you for your attention.